probably the one furthest away. Dr. Chawan is faculty at the University of Mumbai, and he's going to talk about Aniridia management with prosthetic and tinted scleral lenses. Join me in welcoming our faraway visitor attendant.
Thank you, I appreciate it. At the outset, I would like to thank all of you and especially Maria for giving me this opportunity to talk about my new technique, which has a lot of questions. So basically, prosthetic and tinted scleral lenses can be used for a variety of reasons like aniridia, glaucoma, fixed dilated pupil, and I have developed a technique whereby you can infuse the dye pigments into the matrix of the lenses of the material so that it remains forever, and that way it can help. Previously, when I was studying in the Moorfields Eye Hospital, London, they used to do an acrylic coating. The moment you do a coating, the oxygen permeability is lost. Here we are trying to maintain the oxygen permeability. Of course, it is reduced once you do infuse these pigments into the matrix, almost 30%. I got it tested from certain labs, and it does reduce. So, but I'll talk about this more. But it does work wonderfully well if you use high DK materials, more than 120 DK. So when you lose the oxygen transmissibility, it is not zero. In certain papers I have studied and learned is cornea requires about 7 microliters per hour of oxygen, and if you can get anything more than that, is sufficient for the cornea to survive. And especially if the cornea is diseased like keratoplasty or anything else, then the corneal requirement is less. So this is the basis why it works. Of course, there are two ways that I do the prosthetics. One is the tinted lenses, in which you get maximum oxygen permeability. But in many cases like aniridia, when you want to block the excess light, you have to paint it opaque. So when you do the opaque painting, oxygen is gone. But the central window of 4 millimeter and the peripheral zone from 12 millimeter of iris to landing zone of about say 13.5, those two areas are still transparent and allows the oxygen to pass through that material, which reduces almost 70% of oxygen. So you get only 30% of effective oxygen, but still it is double than the requirement of the cornea. The effect of the cosmesis is not always matching because the reflection of the light is from a different meridian, but patients are happy because of the controlled light which is entering in the eye from this artificial pupil that we created. So, of course, when you fit a lens, when you order a lens on an aniridia patients, your power is different. The moment you put in a pupil, the power is going to change. So once you have the lens made with the 4 mm or 5 mm pupil, you may need to refract again and order another lens with that correct power, and then you can do the painting again. We get a lot of good results with this. For kids, I usually use the fenestrated design, where I use 3 fenestrations, equidistant fenestrations in the limbal zone. That is how I learned from Don Ezekiel to fit fenestrated scleral lenses first before I moved to Boston with Perry Rosenthal. So I use fenestrated technique for children especially, and that works fantastic. The advantage of that is there is no suction effect, there is no pressure difference from the atmospheric pressure inside the chamber or outside, so there is no suction, no IOP changes and no mid-day fogging. Of course, I have not used this type of lenses on adults, so I still don't know, but in children's, no problem, you just put in the lens in and it fills up with the patient's own tears. So, and it can be used overnight basis, no need to remove every day. Once in a week you can remove, sterilize and put it back. So, fixed dilated pupil patients after some surgical trauma has benefited, traumatic pupils, a lot of patients with injury, iatrogenic or due to accidents. Post-penetrating keratoplasty was fantastic. I know these are more challenging patients where their demand is more, the fitting has to be perfect, Most importantly, when you use a painted scleral lens, when we use the layer from the back, there has to be sufficient clearance at the limbus. If it's touching or very close to the limbus, you're going to have a lot of complications and problems and failures. So you have to keep in mind to keep that extra clearance. We usually ask about 90 microns of extra clearance all over, including limbus. And of course, if it is a straightforward corneal opacity, then it works fantastic. Of course, the color does not match 100% in different lighting conditions. It looks different, and that has to be borne in mind. If it is brownish color, it usually works, but if it is a lighter color, then there is a challenge. We have used as a cosmetic scleral lens in some patients, and it is fantastic. In fact, one of the patients I work with has a multifocal soft lenses. Aniridia has put that patient, so she was very happy. Just a plain tint on a contact lens, like a soft contact lens, but this is on a scleral lens where you can, get rid of the irregularities on the cornea and get a better vision. But if you can incorporate red, blue, green, whatever tint, it can be used as a therapeutic for dyslexia, headache, post-traumatic injuries, improves contrast, helps with photophobia, helps with color blindness. So it is, it depends on how you want to use this technique. So as this picture shows, there is a opaque layer from the back that stops the light, and if there is you need a tint, then of course it is allowing it's a semi-transparent lens. Peters anomaly patients, as an oculist, I work as an ocularist also. So in many cases of Peters anomaly, previously we used to fit with the PMMA standard scleral gel. The fitting technique of Ocularist is we try to touch all the tissues. But I bring in this scleral lens understanding, and I keep about 250 to 300 micron of space, and patient is absolutely comfortable. And it in fact improves the corneal integrity and helps improve vision as well in many cases. I have treated a lot of patients with diplopia after the retinal surgeries. In fact, there is one patient who just wants to block it. I have given him a black IOL. He has already done the surgery. He is so annoyed, he don't want any vision to go through, any light to go through that eye. Otherwise, he is normal and healthy. So this prosthetic scleral lens works in that case also. You can have a mild to darker tint for various reasons. And this is one patient who was so annoyed that he's a normal patient, but so much redness because of the dry eye. He had tried everything possible. Ultimately, we made a opaque sclera and a normal clear iris in these patients. So just a comparison of soft prosthetic, because we have been fitting soft prosthetic for many years. It works fantastic, but if there is an irregularity on the cornea, and when you want to put a scleral lens to improve vision, this is the choice you have, and it can help with so many other conditions. The fitting process is simple. As you fit your regular scleral lens, you fit it. If it is a tinted scleral lens, then just it's straightforward. You send me the other image of the normal eye. Of course, good image, garbage in, garbage out. So you give a better image of the iris, probably 360 degrees that I can see. Not in the daylight, use a camera flash so I can get a more detail on the iris. And it can be transported, or through the technique it can be matched. We do give some samples, or if you have any samples in mind, you can suggest. This one particular patient I would like to say about is in fact mother of an ophthalmologist. Landed up with glaucoma, lost the cornea, multiple keratoplasties. Ultimately, we gave her with the iris tinted scleral lens, and now she is absolutely normal, leading a good quality of life. So, using this technique can help some of your patients lead a normal life. These are my references. Thank you. I think I
All right, thank you very much for staying on time. It's amazing what we can do with scleral. We open the floor for questions, and the operating rule is you cannot speak unless you have a microphone. There are people like me who won't hear you unless you use the microphone. So we operate on that. We have two people. So we have one of you on my right side, one will be left. And all you have to do is put a hand up and make the questions short so we can get through a lot of comments. Thank you.
Hi, so I have a question for Chandra. You mentioned putting fenestration for lenses on for pediatrics, but leaving them on for a week at a time. I have 3 questions for that. One is who's applying removing? So I guess we can start there. Does the parent do that for the patient?
That's true.
And then second is, are they on prophylactic antibiotics when doing this?
Of course, you have to take care of all the other, like antibiotic cover has to be there.
Okay.
But and also you can squeeze the normal saline through the holes. We have almost 1 millimeter of holes that are quite big for the tear exchange, and you can use one of the holes to just push some little saline in the morning. So it clears up. Usually, I have never seen any midday fogging or any fogging occurring in the chamber, but still you can have one squeeze in the morning, in the night. See, we don't want this. You can, if the child is old enough, you can of course remove it. I'm talking about 7-8 month old babies to about 5-6 year old child.
Okay, so that follows up to my third question. How long do you have these patients on this regimen for, and what dosing and antibiotics?
So as soon as the child is ready to insert a regular scleral lens, I'll switch them over. And till then, of course, we have to take care of all the antibiotics and other problems.
Do you typically do it for like Aniridia patients?
I have done this for aphakic patients.
I'm sorry, that's
Aphakic patients.
Yeah.
Most of
Thank
them.
you.
Okay, we have one over.